In this clinical series, we're taking a deep dive into heart failure. Hi, I'm Dr. Song. I'm an internal medicine physician who started her own clinic called HealthNet Clinic. Let's talk about heart failure. Heart failure is the inability of the left heart to provide organ and body perfusion while maintaining normal pressures. It results from left ventricular dysfunction and ineffectiveness to pump blood to the rest of the body. Heart failure with reduced ejection fraction is defined as left ventricular ejection fraction of less than or equal to 40%. Left ventricular ejection fraction, or LVEF, is the percent stroke volume over end diastolic volume. Heart failure with reduced ejection fraction, or HFrEF, is also called systolic heart failure. Heart failure with preserved ejection fraction, or HFpEF, is defined as an LVEF of greater than or equal to 50%. HFpEF is also known as diastolic heart failure. Heart failure with mildly reduced ejection fraction is defined as LVEF between 40 and 49%. Both systolic and diastolic heart failure can coexist together, but usually one predominates. The pathophysiology of HFrEF involves left ventricular contractile dysfunction. Following an insult, cardiomyocytes begin to lose contractile function, and reduction in stroke volume causes overload. Neurohormonal mechanisms also occur and include increased sympathetic activation and increased renin-angiotensin-aldosterone system activation. These trigger increase in heart rate, heart contractility, peripheral vasoconstriction, and water retention. This stretches the left ventricle and leads to eccentric hypertrophy. Over time, the heart is unable to compensate and leads to reduced cardiac output. The pathophysiology of HFpEF is dysfunction in heart relaxation due to reduced left ventricular compliance. The wall is stiffened from concentric left ventricular hypertrophy and interstitial myocardial fibrosis. Reduced wall compliance impairs heart filling and leads to diastolic failure. Neurohormonal mechanisms, including increased sympathetic output and RAS activation, lead to peripheral vasoconstriction and water retention. This causes a vicious cycle of pump failure. Pulmonary hypertension results from back pressure from the left atrium to the pulmonary veins. The causes of HFrEF include acute myocardial infarction and chronic myocardial ischemia, which leads to acute or gradual contractile function loss. Severe aortic regurgitation or mitral regurgitation also lead to volume overload and eccentric hypertrophy and HFrEF. Severe aortic stenosis leads to concentric hypertrophy and impaired diastolic filling and eventually HFrEF. Other causes of HFrEF include dilated cardiomyopathy, late progression of infiltrative diseases like sarcoidosis, amyloidosis, and hemochromatosis, and later stages of hypertensive heart disease. Causes of HFpEF include chronic hypertension, obesity, diabetes, and sedentary lifestyle, which contribute to wall stiffening and cause myocardial fibrosis. Ischemic heart disease, restrictive cardiomyopathy, and hypertrophic cardiomyopathy also contribute to wall stiffening and cause HFpEF. The clinical presentation of heart failure is often asymptomatic early in the course of the disease. As cardiac output decreases, dyspnea on exertion or shortness of breath and fatigue develop. As fluid is retained in the lungs, orthopnea or inability to lie flat, paroxysmal nocturnal dyspnea or waking up multiple times at night short of breath, and cough with blood may occur. As right heart failure develops, jugular venous distension, lower extremity swelling, and abdominal distension may develop. On physical exam, you may find an S3, a reverberant sound created by abrupt deceleration of blood flow during rapid filling, an S4, a sound heard when blood strikes a stiff left ventricular wall, murmur of secondary mitral regurgitation, laterally displaced point of maximal impulse due to LV enlargement, lung crackles at the bases, and pitting lower extremity edema. ECG shows left atrial enlargement and may show ventricular hypertrophy as well as left bundle branch block. Laboratory findings may include elevated BNP greater than 100, which is highly sensitive for heart failure, though BNP may be falsely low and obesity. Hyponatremia and elevated liver enzymes can be present due to antidiuretic hormone secretion and hepatic congestion, respectively. Chest X-ray may show cardiomegaly or an enlarged heart, pulmonary edema, early B lines, fluffy alveolar infiltrates, and blunting of costophrenic angles. Diagnosis is based on clinical presentation. An echocardiogram confirms the diagnosis. Echo showing LVEF less than 40 confirms HFrEF. Echo showing LVEF greater than 50 in the setting of heart failure symptoms, left atrial enlargement, and left ventricular diastolic
dysfunction
confirm HFpEF. Right heart cath demonstrating elevated filling pressures can determine whether heart failure is due to left or right heart. Most patients should undergo testing for ischemic heart disease with CT or invasive coronary angiography. Other testing may include cardiac MRI or cardiac biopsy. Some differential diagnoses include right heart failure, which can occur due to chronic obstructive pulmonary disease, interstitial lung disease, pulmonary thromboembolic disease, right myocardial infarction, or tricuspid and pulmonic valve disease. Constrictive pericarditis presents similarly to right heart failure. High output heart failure has a different mechanism from HFrEF and HFpEF in that it is due to decreased systemic vascular resistance. Pneumonia can present similarly to acute heart failure exacerbation, but fever, leukocytosis, and BNP less than 100 helps rule it out. COPD exacerbation can present similarly to heart failure, but BNP less than 100 helps rule it out. Nephrotic syndrome and liver cirrhosis can present with edema. Significant pulmonary symptoms are not expected. Management of acute heart failure focuses on stabilizing the patient's vital signs. Intravenous diuretics like furosemide and nitrates can reduce preload and relieve symptoms. Afterload reduction is indicated in patients with high blood pressure. Beta blockers are contraindicated because they decrease heart rate and contractility, which may destabilize the patient. Respiratory failure is treated with positive pressure ventilation or intubation. Patients in cardiogenic shock require inotropic or contractile support with medications like dobutamine. Once stable, the underlying causes should be addressed. Coronary revascularization for ischemic heart disease, valve repair for valvular lesions, and removing insults to the heart like alcohol in alcohol-induced dilated cardiomyopathy. Management of chronic heart failure is called guideline-directed medical therapy, or GDMT. GDMT is different in HFrEF and HFpEF. For HFrEF, GDMT includes an angiotensin receptor neprilysin inhibitor, such as sacubitril/valsartan, or if that's not tolerated, an ACE inhibitor or angiotensin receptor blocker. Beta blockers like metoprolol succinate, carvedilol, and bisoprolol help improve survival. Angiotensin receptor blockers and beta blockers should be gradually titrated to maximum tolerated dose. Loop diuretics such as furosemide should be added to symptomatic patients. Metolazone can be added if volume is resistant to loop diuretics alone. MRAs such as spironolactone and SGLT2 inhibitors such as empagliflozin should be started in symptomatic patients. Combination isosorbide dinitrate and hydralazine can be substituted for angiotensin system blockade in patients who are intolerant. Digoxin can be added if symptoms persist despite other therapy. Pharmacotherapy for HFpEF is less clear. SGLT2 inhibitors should be started first, followed by mineralocorticoid antagonists. Symptomatic patients should be started on loop diuretics. ACE inhibitors can be added as needed. Weight loss and management of associated conditions such as obstructive sleep apnea are beneficial. Cardiac transplant is the definitive treatment for end-stage heart failure. A left ventricular assist device may serve as a bridge before cardiac transplantation. Complications of heart failure include atrial fibrillation, which can disrupt diastolic filling, and cardiorenal syndrome, which shows a prerenal acute kidney injury pattern and is treated with intravenous diuretics. Ventricular arrhythmia and sudden cardiac death are complications in patients with an LVEF less than 30 to 35. It's treated with implantable cardioverter defibrillator. Ventricular dyssynchrony is another complication where the left and right heart do not contract together. A biventricular pacemaker is placed in patients with an LVEF less than 35 and QRS greater than 150. The prognosis of heart failure is as follows. The 1-year mortality rate for NYHA class 1 to 2 or slight limitation in physical activity is 5 to 10%. For NYHA class 3, marked limitation in physical activity is 15 to 20%. And NYHA class 4, inability to perform physical activity without significant discomfort is 30 to 50%. Older age and hospitalization have worse prognosis. Let's talk about aortic regurgitation. Aortic regurgitation occurs when the aortic valve cannot close completely, leading to blood leaking back into the left ventricle. Severe aortic regurgitation causes heart failure when the compensatory mechanisms become overwhelmed. The pathophysiology of aortic regurgitation is commonly due to degeneration of the aortic valve. This increases volume in the left ventricle, which undergoes eccentric hypertrophy. This leads to hyperdynamic circulation. Eventually, contractile dysfunction develops and heart failure becomes decompensated. Cardiogenic shock develops in acute AR. The causes of chronic AR include congenital bicuspid valve, which is most common and occurs in patients less than 30 years old, rheumatic heart disease, infective endocarditis, rheumatoid arthritis, systemic lupus erythematosus, ankylosing spondylitis, giant cell arteritis, and Takayasu arteritis. Genetic syndromes that cause aortic root dilation include Marfan syndrome, Ehlers-Danlos syndrome, and familial thoracic aortic aneurysm. The causes of acute AR include aortic dissection, Staphylococcus aureus, aortic valve endocarditis, and failed repair of aortic stenosis. The clinical presentation of chronic AR can be asymptomatic for many years. Once stroke volume cannot be increased during exercise, patients develop symptoms like dyspnea on exertion, followed by orthopnea and paroxysmal nocturnal dyspnea. Chest pain at night happens due to a drop in aortic diastolic pressure, leading to drop in coronary perfusion. Acute AR presents with rapidly decompensating heart failure. Physical exam reveals a decrescendo diastolic murmur in the left mid-sternal border or the right upper sternal border, depending on if AR is due to valve lesion or aortic root dilation, respectively. It also includes hyperdynamic circulation, which presents with bounding pulses, head bobbing, pounding sensation over chest, water hammer pulse, and pulsations of the uvula. ECG and chest X-ray show left ventricular hypertrophy or enlargement. The diagnosis is suspected based on clinical presentation and confirmed with echocardiography, demonstrating a regurgitant jet from the aorta to the left ventricle during diastole and left ventricular dilation. Greater than 50% regurgitation indicates severe AR. Left ventricular ejection fraction may be normal. Management is with clinical evaluation and echocardiogram follow-up for mild to moderate AR. Asymptomatic patients are monitored with an echo every 6 months. Once contractile dysfunction begins to develop, patients need prompt surgery. Surgical valve replacement is for symptomatic patients, those with severe AR, LVEF less than 55, and LVN systolic dimension greater than 50. Medications such as ACE inhibitors, dihydropyridine calcium channel blockers, and diuretics may be temporarily used to stabilize the patient prior to valve surgery, or in non-surgical candidates. Complications include acute decompensated AR in those whose surgery is delayed, and cardiac arrest in acute AR. Prognosis is favorable for patients who undergo successful valve repair or replacement. Acute AR has substantial mortality, but prognosis is favorable in patients who undergo successful emergency valve surgery. Let's talk about mitral regurgitation. Mitral regurgitation occurs when the mitral valve is unable to close completely, leading to leaking of the blood back into the left atrium. Severe mitral regurgitation leads to heart failure. The pathophysiology is problems with the valve itself called primary mitral regurgitation, or problems with valve closure and normal valve, also called secondary mitral regurgitation. MR can be chronic or acute. In chronic MR, the left atrium increases compliance and left ventricle becomes eccentrically hypertrophied. Sympathetic and RAS activation improve stroke volume, but eventually the heart is overwhelmed and heart failure progresses. In acute MR, the left atrium and ventricle don't have time to adapt, and decompensated heart failure rapidly develops. The causes of chronic MR include myxomatous degeneration of the mitral valve, manifesting as mitral valve prolapse. It's associated with Marfan syndrome or Ehlers-Danlos syndrome. Rheumatic MR affects patients less than 30 years old. Other causes include infective endocarditis or atrial septal defect associated with Down syndrome. Chronic secondary MR results from heart failure where the ventricles dilate and displace the mitral valve. Acute MR is caused by papillary muscle rupture, spontaneous chordate tendinate rupture, staphylococcal aureus mitral valve endocarditis, failed repair of mitral stenosis, and other intracardiac procedures. The clinical presentation of chronic MR is asymptomatic for years in mild or moderate MR. Once heart failure develops, dyspnea on exertion is followed by orthopnea and paroxysmal dyspnea, jugular venous distension, and lower extremity edema. Atrial fibrillation is initial symptomatic presentation of chronic severe MR. The presentation of acute MR is shock. Physical exam demonstrates hollow systolic murmur at the cardiac apex. A mid-systolic click followed by systolic murmur happens in mitral valve prolapse. S3 and laterally displaced point of maximal impulse are heard. ECG shows left atrial enlargement and possible atrial fibrillation. Chest X-ray shows enlarged left atrium and ventricle and may show pulmonary edema. The diagnosis is suspected based on clinical presentation and confirmed with echo demonstrating regurgitant jet from the left ventricle to the left atrium. Regurgitation of greater than 50% stroke volume indicates severe MR. Management of chronic primary MR is with mitral valve repair or replacement. The timing of surgery can be challenging. The goal of echo surveillance is to optimize the timing so patients can use their own valve for as long as possible and undergo surgery early enough to prevent irreversible left ventricular dysfunction. In asymptomatic patients with severe chronic primary MR, echo is recommended every 6 to 12 months. Surgery is recommended when patients develop symptoms. Left ventricular dilation is found, or LVEF is between 30 to 60, since an LVEF of less than 60 indicates contractile function has already declined. In patients whose valves can be repaired, they should undergo surgery when they are asymptomatic with LVEF greater than 60 or symptomatic with LVEF less than 30. Medical therapy with diuretics, ACE inhibitors, dihydropyridine calcium channel blockers, or beta blockers are used while patients await surgery or in non-surgical candidates. To manage chronic secondary MR, the underlying cause should be treated. A transcatheter and mitral valve clip may be helpful. To manage acute MR, emergency valve surgery is required. Aortic balloon pump can be a temporizing measure prior to surgery. Complications of MR include HFrEF, cardiogenic shock, atrial fibrillation, pulmonary hypertension, and right-sided heart failure. The prognosis is good for patients who undergo successful valve surgery, with repair surgery faring better than replacement due to lower risk of thromboembolism and endocarditis. However, untreated chronic severe MR is fatal. For acute MR, which is associated with high mortality, the prognosis is favorable in patients who undergo successful emergency valve surgery. Let's talk about dilated cardiomyopathy. Dilated cardiomyopathy is one of the major causes of HFrEF. The pathophysiology is a direct insult to cardiomyocytes, myocardial fibrosis, and compensatory eccentric hypertrophy. Blood flow is initially compensated but eventually the LV is overwhelmed and heart failure develops, and stroke volume drops. DCM may be reversible if the insult is removed before substantial myocardial fibrosis develops. Causes of dilated cardiomyopathy include myocardial infection with Coxsackie virus, adenovirus, influenza, HIV, Chagas disease, or Lyme disease. They also include toxic insults like alcohol, cocaine, amphetamines, arsenic, mercury, and cobalt. Cancer drugs such as trastuzumab and doxorubicin also cause DCM. Trastuzumab DCM is reversible, while doxorubicin DCM is not. Other causes of DCM include classic familial DCM, Duchenne muscular dystrophy and Becker muscular dystrophy, amyloidosis, sarcoidosis, hemochromatosis, systemic lupus erythematosus, rheumatoid arthritis, dermatomyositis, giant cell arteritis, hyperthyroidism, hypothyroidism, acromegaly, and pheochromocytoma. Nutritional deficiencies like thiamine and selenium also cause DCM. Peripartum cardiomyopathy and tachycardia-induced cardiomyopathy, where the ventricles contract at greater than 120 beats per minute for several weeks, can cause DCM. The clinical presentation is asymptomatic early in the course of disease, and later typical signs and symptoms of heart failure, including dyspnea, peripheral edema, laterally displaced point of maximal impulse, secondary mitral regurgitation murmur, and S3. The diagnosis is suspected based on clinical presentation and confirmed with an echo demonstrating LV cavity dilation and LVEF less than 40. Additional testing to confirm the underlying cause include TSH, iron studies, heavy metal levels, cardiac MRI with gadolinium contrast, CT or invasive coronary angiography to rule out ischemic disease, endomyocardial biopsy for rapidly progressive DCM, and genetic testing. The management involves stabilization in patients who have decompensated heart failure, goal-directed medical therapy in patients with chronic heart failure, treatment of underlying conditions, and cardiac transplantation with LV assist device as bridge for end-stage heart failure. DCM is the most common indication for heart transplantation. The complications of DCM include ventricular arrhythmias leading to sudden cardiac death, and LV neurothrombus leading to stroke, acute mesenteric ischemia, or acute limb ischemia. In these cases, an ICD and anticoagulation are indicated, respectively. DCM has a poor prognosis, with one-year mortality rates ranging between 5 to 50%, depending on the severity of symptoms. Let's talk about hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is an inherited heart disease that typically develops in adolescence. The pathophysiology includes abnormal contractile proteins, microvascular ischemia, and interstitial fibrosis in the heart muscle. Dynamic left ventricular outflow tract narrowing or obstruction occurs when the heart contracts because of septal enlargement and abnormal motion of the mitral valve. HOCM is inherited in an autosomal dominant way, but disease also occurs in patients without family history, and patients with the mutation do not always have the disease. Pathology shows increased thickening prominently in the interventricular septum, and histopathology demonstrates cardiomyocyte hypertrophy with disorganized arrangement and prominent interstitial spacing with fibrosis. Symptoms include fatigue, exertional chest pain or shortness of breath, palpitations, and lightheadedness. Edema is uncommon. Many patients are asymptomatic. Physical exam demonstrates a crescendo-decrescendo systolic murmur that increases or decreases in intensity with maneuvers that decrease or increase blood volume, respectively. ECG shows high voltage QRX complexes and repolarization and depolarization changes. Diagnosis is suspected based on history. Echo showing wall thickness greater than 15 millimeters in any portion confirms the diagnosis. Exercise testing with echo evaluates the degree of LVOT obstruction. Patients with LVOT gradient greater than 30 is said to have obstructive HOCM, and gradient less than 30 is called non-obstructive HOCM. Ambulatory ECG monitors for paroxysmal atrial fibrillation or ventricular arrhythmias. Patients should have repeat echo and ambulatory ECG every 1 to 2 years. Complications of HOCM include arrhythmias, exertional syncope, and sudden cardiac death. Management includes beta blockers, non-dihydropyridine calcium channel blockers, ranolazine disopyramide, and mavacamten. Diuretics are used for heart failure, but avoided if no symptoms are present. Patients should maintain good oral intake and avoid dehydration. Nitrates, dihydropyridine calcium channel blockers,
diuretics,
and ACE inhibitors are avoided. Alcohol septal ablation and surgical myectomy are for patients refractory to medical therapy. ICD is indicated when there's a high risk of sudden cardiac death. Cardiac transplantation is definitive treatment. Screening is done in all first-degree relatives. The prognosis of HOCM is that most patients have normal life expectancy. Women have a slightly worse prognosis, possibly due to bias and delayed recognition. Let's talk about restrictive cardiomyopathy. Restrictive cardiomyopathy is the least common type of cardiomyopathy. The pathophysiology is ventricular wall stiffening. Causes include amyloidosis wild type, sarcoidosis in a minority of patients, hemochromatosis, gene mutations affecting sarcomere and desmosome protein, chest radiation therapy, systemic sclerosis, eosinophilic endomyocardial fibrosis. The clinical presentation is early asymptomatic period, followed by later heart failure. Rapid Y descent is found in jugular venous pressure waveform. ECG and echo show biatrial enlargement, normal QRX complexes, diastolic dysfunction, normal systolic function. Additional tests confirm the underlying cause, such as urine protein electrophoresis, cardiac MRI with gadolinium, endomyocardial biopsy, and genetic tests. Differential diagnosis includes constrictive pericarditis. Constrictive pericarditis shares similar signs and symptoms to RCM, but also has a pericardial knot and pericardial calcification found on CT, X-ray, or cardiac MRI. It's caused by recurrent pericarditis, recent heart surgery, or tuberculosis. It's treated with pericardiectomy. RCM is managed with diuretics. GDMT is avoided unless there's a separate indication, since they can impair diastolic filling. Autologous hematopoietic stem cell transplant and/or chemotherapy for AL cardiac amyloidosis. Transthyretin protein stabilizers for ATTR cardiac amyloidosis. Glucocorticoids or immunosuppressants for sarcoidosis. Phlebotomy or iron chelation therapy for hemochromatosis, and cardiac transplantation for end-stage heart failure. Complications include atrial fibrillation, atrial ventricular block, renal failure, and hepatic congestion. The prognosis of RCM is poor, with a high percentage progressing to end-stage heart failure. Let's talk about peripartum cardiomyopathy. Peripartum cardiomyopathy is an uncommon but life-threatening form of dilated cardiomyopathy. Its pathogenesis is multifactorial, occurring in susceptible patients with pregnancy-related stressors. Risk factors include maternal age greater than 30, multiple parity, multiple final gestation, history of hypertension in pregnancy, and cocaine or tobacco use. Symptoms include fatigue, dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, cough with occasional hemoptysis or blood, jugular venous distension, pitting feet edema, and abdominal distension. Physical exam shows a laterally displaced point of maximal impulse. The differential diagnoses include physiologic changes of pregnancy, but acute dyspnea, tachycardia, hypoxemia, chest pain, or altered mentation suggest a pathological process. It also includes preeclampsia, and patients may have both, other dilated cardiomyopathies, and pre-existing valvular or congenital heart disease. The diagnosis is based on 3 clinical criteria: symptoms in the last month or 5 months following delivery, LVEF less than 45, and no other cause of heart failure. Labs show significantly elevated BNP and mildly elevated troponins and liver enzymes. Echo shows reduced left ventricular ejection fraction, left ventricular dilation, and pulmonary hypertension. ECG is done to rule out alternate diagnoses. Management requires a multidisciplinary approach with obstetrics, cardiology, critical care, and anesthesia. If peripartum cardiomyopathy develops before delivery, vaginal delivery is preferred, and C-section is reserved for patients who require circulatory support. Supportive therapy may include endotracheal intubation, LV assist devices, extracorporeal membrane oxygenation, or ICD. In acute decompensated heart failure, intravenous loop diuretics and nitrates are used, while beta blockers and dobutamine are avoided. During pregnancy, combination isosorbide dinitrate and hydralazine, loop diuretics, metoprolol, and digoxin are used, while other elements of GDMT are avoided. During postpartum breastfeeding, SGLT2 inhibitors are avoided. During postpartum without breastfeeding, GDMT is followed for at least 6 months and tapered after LVEF reaches greater than 50%. In patients with risk of clots, low molecular weight heparin is preferred during pregnancy, and unfractionated heparin is preferred near delivery. Complications include ventricular arrhythmias, thromboembolism, and heart failure. The prognosis depends on the degree of LV dysfunction at the time of diagnosis. Mortality is 1 to 3% within the first month and 3 to 15% within 3 years. Recovery occurs in approximately 70% of patients within 12 months. Recurrence occurs in 20% of patients. Prevention focuses on contraception with progesterone-only implants and IUDs, since estrogens increase clot risk. Aspirin may be used in subsequent pregnancies, and high-risk pregnancies are often terminated. Let's talk about high-output heart failure. High-output heart failure is an uncommon type of heart failure. It results from low systemic vascular resistance, and the heart increases stroke volume initially, but eventually becomes overwhelmed and unable to keep up. Causes include acquired AV fistula, such as a traumatic penetrating injury to the artery and adjacent vein, hemodialysis AV fistula, congenital AV malformation, and Paget disease. Hyperthyroidism, severe anemia, thiamine deficiency, myeloproliferative disorders, and chronic lung diseases by increasing metabolic demand. Morbid obesity and cirrhosis are also causes. The clinical presentation includes bounding pulses, warm extremities, brisk carotid upstroke, and wide pulse pressure. Labs show elevated BNP. Diagnosis is suspected based on clinical presentation and confirmed with echocardiogram and right heart cath. Echo shows dilated left ventricle, right ventricle, and inferior vena cava. Right heart cath shows elevated PCWP greater than 16, cardiac index greater than 4, and cardiac output greater than 8. Mixed venous oxygen saturation is elevated due to lower oxygen extraction in the peripheral tissues. Management involves diuretics. Peripheral vasodilators, like ACE inhibitors, are avoided. Hospitalized patients with high-output heart failure have similar mortality rates to HFrEF patients. In this clinical series, we went over HFrEF, HFpEF, dilated cardiomyopathies, restrictive cardiomyopathies, high-output heart failure, peripartum cardiomyopathy, and hypertrophic cardiomyopathy, as well as valvular diseases. If you would like more information or would like to book an appointment, visit us online at www.healthnetp.com.